This video will be about obstructive shock. Obstructive shock is associated with an actual obstruction of the great vessels or the heart. So there is something physically blocking the blood flow. The heart is pumping well, but there's something blocking the flow, so it cannot deliver adequate oxygen and nutrients to the organs. Most commonly, an obstructive shock is caused by a cardiac tamponade or a pulmonary embolism. And here is a picture of cardiac tamponade. You can see the fluid here in the pericardium that is causing a lot of pressure in the heart, obstructing it from pumping like it should. Some symptoms of obstructive shock are cold and clammy extremities, shortness of breath, tachycardia, tachypnea, confusion, altered mental status, decreased urinary output, chest pain or pressure, increased work of breathing, decreased peripheral pulses, jugular vein distension, and poor capillary refill. Hemodynamics will be monitored using a Swan-Ganz catheter. Patient will be hypotensive. Pulmonary capillary wedge pressure will be increased. Cardiac output is decreased. The SVR is increased. The MAP will be normal or decreased. The CVP is increased, and the O2 in the vein is decreased. Medication options. Oxygen will improve the oxygenation status, so we're going to give them oxygen. The volume expansion with blood, plasma, or the isotonic sodium chloride. This is going to maintain adequate intravascular volume as needed. Anticoagulants and clot busters to thin the blood, easing the blood flow. This is if the shock is caused by pulmonary embolism. The medications are limited if the shock is caused by cardiac tamponade. The first-line treatment for a cardiac tamponade is going to be performing the pericardiocentesis to withdraw the fluid that is compressing the heart to relieve the pressure. And that is shown here on this picture. ABG values, you will likely see an uncompensated metabolic acidosis with hypoxemia. The pH is going to be low. You'll have an increased CO2, a decreased bicarb, and a decreased PaO2. Your ventilator treatment is going to be invasive mechanical ventilation with intubation to maintain the airway. If the shock is caused by a cardiac tamponade, you do not want to apply the positive pressure ventilation until the pericardiocentesis has been performed to relieve that pressure, because the positive pressure from the ventilation will just increase all of that pressure on the heart, causing more harm to the patient. Even after the procedure has been performed, you'll still want to closely monitor the hemodynamics once you have applied any positive pressure ventilation, just to ensure that those levels are still in a safe range. You're going to base your initial settings off of the ABG results and the patient's ideal body weight, using the standard 6 to 8 mLs per kg of ideal body weight for the tidal volume. And initially, you will want full ventilator support. And here are my sources.